Welcome to the program. I'm Sarah, and today we are venturing into a territory of Parkinson's disease that is often discussed in whispers or sometimes not at all. We are talking about the psychosis spectrum.
It's a vital topic, Sarah. When people think of Parkinson's, they think of the shaking palsy, the tremors, the rigidity, the slow movement. But for many patients and their families, the most disruptive symptoms aren't the ones you can see on the outside. It's the hallucinations and delusions that emerge as the disease progresses.
Historically, we viewed these symptoms as a side effect of the medication, too much dopamine, but our modern understanding has evolved. We now see psychosis as an intrinsic part of the Parkinson's disease psychosis spectrum.
It's incredibly common, affecting up to 50% of patients over the course of their disease. And yet, it remains underreported because patients are often afraid of being labeled as crazy.
Today, we're going to break that stigma. We'll look at the minor phenomena that start the spectrum, the biological, chemical cocktail that drives it, and the latest treatment targets, including the first FDA-approved medication specifically for PDP.
Sarah, let's talk about the word spectrum. Because PDP doesn't usually start with a full-blown delusion, it starts subtly.
It really does. The spectrum begins with minor phenomena. The most common is the presence hallucination, that distinct feeling that someone is standing right behind you or in the next room, even when you know you're alone.
Or passage hallucinations, where a patient sees something, a small animal or a person, flicking across their peripheral vision. They turn to look and nothing is there.
At this early stage, insight is usually preserved. The patient knows it isn't real. They might say, "I saw a cat run under the table, but I know I don't own a cat." This is what we call benign hallucinations.
But as the disease progresses, those shadows become formed visual hallucinations. They see people, often children or deceased loved ones, sitting in the room. They might look incredibly vivid, wearing specific clothes, showing specific expressions.
And eventually, the benign becomes distressing. Insight begins to fade. This is when we move into delusions.
Delusions in PD are often paranoid or persecutory. The two most common are spousal infidelity and theft. A patient might become convinced their partner is cheating or that family members are stealing their money. This is the point where the bed assignment or the home environment becomes a battlefield.
Let's get into the why. Why does a motor disease cause people to see things that aren't there?
It's a triple threat of neurotransmitters: dopamine, serotonin, and acetylcholine.
The classic theory was always the dopamine hypothesis. We give Levodopa to help the motor symptoms in the striatum, but that extra dopamine spills over into the mesolimbic pathway, the part of the brain that handles reward and perception.
But we've learned it's more than just too much dopamine. There's a massive serotonin component. Specifically, the 5-HT2A receptors in the visual cortex become hypersensitive. They're misfiring, creating images out of thin air.
And there's the acetylcholine piece. We see a loss of cholinergic neurons in the nucleus basalis of Maynard. This is the same mechanism we see in Lewy body dementia. When you lose acetylcholine, you lose the filter that separates your dreams from your reality.
It's like the brain is stuck in a permanent state of REM sleep behavior disorder, where the dream world starts leaking into the waking world.
As clinicians, we need to know who is at the highest risk. Sarah, what are the red flags?
Age and disease duration are the big ones. The longer you have PD, the higher the risk. But cognitive impairment is the #1 predictor. If a patient is starting to show signs of dementia, psychosis is often right around the corner.
Also, watch the sleep. Vivid dreaming and REM sleep disturbances are often the early warning system for hallucinations.
And for the bedside nurses, watch out for the sudden change. If a stable PD patient suddenly starts hallucinating wildly, don't assume it's the Parkinson's progressing.
Right. It's almost always a trigger, a UTI, pneumonia, dehydration, or a change in a non-PD medication, like a bladder antispasmodic or a narcotic.
This is why the first step in the treat-to-target approach is always rule out infection.
Okay, we've ruled out the UTI. The patient is still seeing figures. What is the pharmacological ladder?
Step 1, simplify the PD meds. We usually start by tapering off the extra meds, anticholinergics like Artane first, then amantadine, then MAOB inhibitors. We try to get back to monotherapy with Levodopa if possible.
But sometimes, if we lower the meds too much, the patient can't walk. It's a terrible trade-off. Do you want to see the cat, or do you want to be able to get to the bathroom?
This is where antipsychotics come in. But in PD, we have a major rule. Never use typical antipsychotics like haloperidol. They block D2 receptors and will lock the patient into a state of stone-like rigidity.
For years, we used quetiapine off-label. It's well tolerated, but the clinical trials for its efficacy in PD are actually quite weak.
Then there's clozapine. It's the gold standard for efficacy, but the black box of agranulocytosis in the weekly blood draws make it very difficult to manage for an elderly patient with mobility issues.
And that brings us to the new player, Pimavanserin.
Pimavanserin changed the game because it is not a dopamine blocker. It's a selective 5-HT2A inverse agonist. It targets the serotonin misfiring without touching the dopamine receptors in the motor center.
It's the only drug that allows us to treat the psychosis without making the motor symptoms worse.
As we wrap up, Sarah, let's talk about the human side. PDP is the #1 reason patients with Parkinson's are placed in nursing homes.
It's caregiver burnout. A spouse can handle the tremors and the slow walking, but they can't handle the paranoia and the sleepless nights when their partner thinks they are a stranger.
Our job as nurses is to ask. Don't wait for the patient to tell you. Ask, have you been seeing things out of the corner of your eye? Have you been having vivid dreams lately?
Normalize it. Tell them, this is a part of the disease and we have ways to help.
To recap, identify the spectrum. Start with the presence and passage hallucinations. Pathophysiology, it's a serotonin and dopamine imbalance. Manage, rule out infection, simplify meds, and consider 5-HT2A targets like Pimavanserin.
This has been a deep dive into the shadows of PD. Thanks for joining us.
Stay curious, keep assessing, and we'll see you next time.